Hello, all the budding neurosurgeons, may it be the aspirants or the neurosurgery residents. I'm Dr. Skanda. I have completed my neurosurgery residency from All India Institute of Medical Science a few years back. The sole purpose of having this channel is to help the budding residents academically, may it be for your entrance exam or it could be a board exam. Whatever it is, I hope that the contents which are here will help you to excel in your exam. So without wasting much time, let's get into today's topic, that is abnormal carotid vertebro-basal communication or anastomosis. What are those? Let's go and check. Okay, so the word is persistent carotid vertebro-basilar anastomosis. So the word is self-explanatory. I'm sure all of you know about the two primary circulation to the brain, that is the anterior circulation, which is the carotid circulation, of course, on either sides, and the posterior circulation, which is vertebro-basilar system. So what happens is that I'm sure all of you know about the one which is one communication between the anterior and posterior, which is existent in almost all the patients or all the human beings. That is the PCOM artery, or the posterior communicating artery, which arises from the terminal part of the ICA and then joins the junction of P1 and P2. So that is not abnormal. Having PCOM is obviously a normal thing. So today let's talk about the abnormal communications. So there are 4 of those, and the most common, although when I say most common, it is not actually very common. The condition itself is very rare, but among those, the most common is persistent primitive trigeminal artery, or PPTA. So before talking about these, I think it's better if we just talk about what is called as Bouthilier classification of the ICA. Have a look at this picture. Ignore the first two. These are different classifications which are not important. Have a look at this third picture. This is the Bouthilier classification of the internal carotid artery. After the common carotid artery, which is here, bifurcates into external carotid and internal carotid, till it bifurcates into anterior and middle cerebral artery. The course of the ICA is divided into 7 different segments. The first one, or the C1, is the cervical ICA, which is obviously extracranial. So the C2 is the petrous ICA. This petrous ICA is again divided into the vertical part and the horizontal part. This region is the carotid canal, where it gets into the skull. So then you have C3, which is the lateral part, that is, it comes out into intracranial segment. And then C4 is the cavernous ICA, that is where it is in the cavernous sinus. Then after coming out of the cavernous sinus, we have the C5 segment, that is the clinoidal segment. And after that, we have the ophthalmic segment. It is obviously called so because of the ophthalmic artery which originates from the anterior part of it. And after that, we have the communicating segment, or it's also called as bifurcating segment. So this is the terminal part. It's called as a communicating segment because of the posterior communicating artery. So now, once you know about this classification, let's have a look at this scan. Again, the same thing is shown here. This is almost the region where CCA divides into ICA and ECA. Sorry, this is the part, and then this is the C1, which is the cervical segment, and C2, which is the petrous, vertical petrous and horizontal petrous. C3, which is the lateral part. C4 is the cavernous part. C5 is the clinoidal part. C6 is the ophthalmic part. You're seeing the ophthalmic artery coming here, and then you have the C7, or the communicating part. So once you are aware of this, let's go back to our persistent carotid vertebro-basilar anastomosis. So as I told, as such, this is a rare thing, but among this, the most common is persistent trigeminal artery, also called as persistent primitive trigeminal artery, PPTA. So where does it arise from? It arises from the proximal cavernous ICA. So which was the cavernous ICA? Cavernous ICA was C4. So it arises from the proximal part of the cavernous ICA and obviously connects to the vertebro-basilar system. So this again can be divided into two types, lateral and medial. There is something called as Saltzman classification of this. So which can be again type 1 or type 2. Type 1 is this with absent ipsilateral posterior communicating artery, and type 2 is fetal origin of ipsilateral posterior communicating artery. Now let's try to understand each of these things. So I told type 1 is PPTA with absent posterior communicating artery. So what is generally the importance of posterior communicating artery? See, posterior communicating artery basically communicates anterior and posterior segment. So what happens in case if there is some amount of vascular compromise in one of the system, the other system can compensate for it through this communication, which is the posterior communicating artery. So in type 1 PPTA, posterior communicating artery is absent. So what does it mean? It means PPTA is very important in these patients because there is no other PCOM. And then you have type 2, that is a condition where there is a fetal origin of ipsilateral posterior communicating artery. So the next question is that what is the fetal origin of posterior communicating artery? So see, generally what happens is the anterior circulation and posterior circulation are self-sufficient. The cross flow is not necessary. But in case of a fetal posterior communicating artery, what happens is that the P1 segment of the PCA is very narrow. So as a result, the posterior circulation is dependent on the anterior circulation. There is blood flow from ICA through the PCOM to P2 and to the rest of the posterior circulation. So in this case, if the PCOM gets compromised, patient will have infarct in the region supplied by the vertebro-basilar artery because it is not self-sufficient. It is dependent on the anterior circulation through the PCOM. Okay, coming back to our persistent carotid vertebro-basilar anastomosis, the other thing we have is persistent otic or acoustic artery. It is very controversial and it's not very sure if it really exists at all or not. So it arises from the Petrus ICA. So which was the Petrus ICA? Petrus ICA was the second part in the Bouthilier classification. It is very rare because normally it is the first anastomosis to regress. Following this, we have a persistent hypoglossal artery. It arises from cervical ICA at C1 to C3 levels. C1 to C3, when I say, I'm not talking about the Bouthilier classification, I'm talking about the vertebral levels. The final one is the persistent proatlantal artery. This again has two types, type 1 and type 2. Type 1 arises from the internal carotid artery, that is, it connects the internal carotid artery to the vertebro-basilar system, while type 2 arises from the external carotid artery. It connects the ECA into the vertebro-basilar system. So just to make things easy for you, there is a mnemonic which is hot pepper. So if you are someone who likes to remember things with mnemonic, then yes, you can make use of that. So now that we spoke about all these things, it is very important that we should know something about its clinical significance. A few of the things I told you, that is type 1 and type 2 Saltzman classification in case of PPTA, I have already told you. But in addition to that, see, the thing is that any abnormal artery will lead to turbulence of flow. So it can cause problem. It can cause aneurysm. It can cause aneurysm development. It can cause stasis or thrombosis, etc. But something which is more important than that is in case of an aneurysm in the cavernous ICA, the most commonly done procedure is to ligate it on both sides. The surgical procedure, I'm not talking about the endovascular, it is to ligate the ICA proximally and distally beyond the cavernous segment and give ECA to ICA bypass. But in this case, if you do that, that is not going to be useful because there will be circulation from posterior to this ligated part, which is going to have the aneurysm through this PPTA. So whenever you plan such a procedure, it is very important that you do all the necessary tests of course DSA and rule out the presence of PPTA. Apart from PPTA, the other vessels as such, if I have to tell, practically there is not much of significance. But yes, it is very important that if you are planning for any vascular procedures, it is important that you keep that in mind and rule that out.